Adenomas of breast. The adenoma is a generic term applied for a benign glandular epithelial tumor in the breast. They are derived from a proliferation of the terminal duct unit, which result in a discrete mass which corresponds to a well-circumscribed mass on clinical examination and imaging. They contain variable proportion of glandular, fibrous, and fatty tissue. The specific name to adenoma is given depending upon the dominant proliferating cell type and its ratio to other cell. Tubular adenoma. It is a benign, well-circumscribed tumor which is composed of a dense proliferation of closely packed, round and oval tubular structures consisting of bilayered ductal and myoepithelial cells with little background stroma. Location: they arise in the upper outer breast quadrant. Clinical features: they are slowly growing neoplasm. They may present as a palpable, solitary, painless mass which is freely mobile and well defined. They usually occur in young premenopausal women of childbearing age. In 90% of cases, the age is below 40 years. They rarely arise before menarche and after menopause. Studies show that tubular adenoma and fibroadenoma share a common histogenetic mechanism. The stromal component dominating in fibroadenoma, whereas the epithelial and myoepithelial cells dominate in the tubular adenoma. Gross appearances: the tumor size is generally 1 to 7.5 centimeter, averaging 3 centimeter. However, giant forms are as large as 15 centimeter has also been reported. They are smooth, rounded, unencapsulated, firm tumors which have a solid, homogeneous or micronodular rubbery appearance on cut surface. They are yellow to tan brown in color and are rather soft when compared with fibroadenoma. Microscopic features: on low power, the tubular adenoma, a sharply demarcated, compact proliferation of small, uniformly rounded and regular tubular structures. The tubules are lined by a double layer of cells, that is, the inner layer of ductal luminal cells and an outer layer of myoepithelial cells. Rarely, nucleoli, atypia, and mitosis are present. The lumens of these tubules are usually empty, but at times contain mucin or PAS positive eosinophilic proteinaceous material. There is scanty intervening stroma containing a few scattered lymphocytes. There is no risk of developing malignancy in tubular adenoma. Now this is the photograph showing microscopic features of tubular adenoma, in which there are densely packed ductal structures lined by epithelium and myoepithelial cells. There is a letter T in the photograph from which yellow arrow points towards the ductal structure. The intervening stroma is marked with letter S. Lactating adenoma. It is a benign breast nodule which is diagnosed during pregnancy or breastfeeding, consisting of aggregates of glands showing lactational changes. They are soft, painless, palpable, solid, mobile, discrete mass without any skin or nipple changes. They are usually less than 5 cm but have the potential for rapid growth and may enlarge up to 25 cm in size. They regress in size in 1 to 5 months after termination of breastfeeding. Location can be seen either single or bilateral, multifocal in the breast tissue and rarely seen along the milk line from groin to axilla. Gross appearances: they are well circumscribed, unencapsulated, lobulated solid masses with a firm to rubbery grayish tan to yellow appearance on cut surface. Microscopic features: there is proliferation of benign ducts with preservation of a lobular architecture. These secretory lobules are separated by scanty connective tissue which may be oedematous. They are sharply demarcated from the surrounding breast tissue. The ducts lined by benign appearing epithelial cells with vacuolated cytoplasm and may show hobnail appearance. The ductal lumina contain eosinophilic secretions which oil red O are positive. Now the photograph showing lactating adenoma. The ducts are lined by secretory epithelium which is vacuolated. The lumens contain secretory material. In many areas, the nuclei of the cells show hobnail appearance which is labeled. This is another photograph of lactating adenoma of breast showing marked secretions which are labeled with letter S. Apocrine adenoma, an extremely rare lesion. It presents as a discrete mass, homogeneous throughout, sharply demarcated from the surrounding breast tissue. It is composed of benign breast ducts with apocrine epithelium and minimal supportive stromal component. Often shows papillary and cystic architecture. This is the photograph showing microscopic features of apocrine adenoma in which the ducts are lined by cells having eosinophilic granular cytoplasm and hyperchromatic nuclei. Ductal adenoma. It is a benign tumor composed of distorted glands in a sclerotic stroma surrounded by a fibrous capsule. Location: the ductal adenoma arise in a medium or small sized ducts of peripheral breast. Clinical features: the ductal adenoma usually presents as a palpable solitary lump, but it may have an irregular appearance when multifocal. It usually arises from the small and medium-sized ducts. Pathogenesis: hypothetically, it is believed that the ductal adenoma most likely arise from intraductal papilloma in a small and medium-sized duct. This is due to a stromal repair process that the intraductal papilloma may undergo sclerosis, which is manifested by a fibroblastic proliferation. Macroscopic appearances: the ductal adenomas range from 0.5 to 5.0 centimeter in size and present as a discrete white solid nodule. On cut surface, they are lobulated and granular with central gray softening. Calcified areas may show firm, gritty, and pseudo-invasion. Rarely, the tumor may have a poorly defined edge that is firmly adherent to the surrounding breast stroma, raising suspicion for an invasive carcinoma. Microscopic features. The ductal adenoma is usually a solitary solid adenomatous proliferation which is surrounded by a densely thickened concentric fibroelastic wall, but it may be multinodular. The adenomatous portion consists of glands arranged in organized parallel patterns radiating outward from the center to the periphery. The glands range in shape from round to oval or elongated to branched. They are composed of a bilayer of luminal, ductal, and myoepithelial cells with a small amount of intervening fibrous tissue. The capsule is laminated and hyalinized. Now the photograph shows microscopic features of ductal adenoma. In this photograph, you can appreciate a discrete, solid adenomatous proliferation surrounded by thick concentric sclerotic wall that entraps glands, resulting in a pushing or pseudo-infiltrative borders. This is the high power view showing round to oval elongated to branching glands composed of a bilayer of luminal, ductal, and attenuated myoepithelial cells, focally appearing pseudo-invasive. Fibroepithelial tumors of breast, and amongst that, the most important is fibroadenoma. Fibroadenoma is a very common benign lesion of the breast, commonly seen in younger women. It presents as a round, well-circumscribed, discrete, non-tender, palpable breast mass. It is typically solitary but may be multifocal or bilateral. Giant fibroadenomas are larger than 5 cm or weigh more than 500 gram. Gross appearances, it is tan white to gray, firm to rubbery, round to oval mass. It is well circumscribed and encapsulated. There is no infiltration into surrounding breast fatty tissue. Most fibroadenomas measure up to 3 cm in size. Microscopic features. This benign tumor arises from lobules and stroma of the terminal duct lobular unit. It shows a well-defined capsule. The characteristic features include a collagenous stroma and distorted slit-like elongated ducts. There is a variable degree of stromal cellularity. The common associated findings are fibrocystic changes, apocrine metaplasia, adenosis, ductal epithelial hyperplasia. The benign multinuclear giant cells may also be seen. Now the photograph shows a well circumscribed grayish white oval to round mass which is rather lobulated on cut surface. This is the photograph showing microscopic features of intracanalicular fibroadenoma, in which the ductal structures, they are compressed to slit-like spaces by the surrounding loose fibrous tissue. Another photograph showing microscopic features of fibroadenoma with pericanalicular growth pattern, in which you can appreciate that the ductal structures they retain their lumina and they are surrounded by loose fibrous stroma. The glandular elements are composed of two cell layers, an inner epithelial layer and an outer myoepithelial cell layer. Some fibroadenomas, especially those arising in the second decade of life, can grow rapidly and appear quite cellular. Such lesions are called cellular fibroadenomas. This is the photograph which shows cellular fibroadenoma with uniform hypercellular stroma. Myxoid fibroadenoma display a prominent myxoid changes in the stroma. Fibroadenomas may undergo changes such as infarction or prominent hyalinization of the stroma with or without calcification. This microscopic photograph shows fibroadenoma with myxoid hypocellular stroma. Another photograph showing fibroadenoma with prominent stromal hyalinization. This is the photograph which shows fibroadenoma with cystic changes. Fibroadenomas with extensive epithelial proliferation have been termed as complex fibroadenomas. This photograph shows microscopic features of complex fibroadenoma showing pericanalicular pattern and cystic changes. Phyllodes tumor. Phyllodes tumor is generally a circumscribed fibroepithelial neoplasm showing a prominent intracanalicular architectural pattern with leaf-like stromal fronds which is capped by luminal and myoepithelial cell layers accompanied by stromal hypercellularity. Now this should be the definition of phyllodes tumor. Phyllodes tumor accounts for less than 3% of the fibroepithelial lesions of breast. Usually affects adults in their 50 and 60 decades of life, but rarely found in pediatric age group. There is a history of a rapidly growing, discrete, palpable breast mass. Gross appearances, it is variable sized, discrete, tan gray mass which is firm in consistency. There is a variegated and lobulated appearance on cut section. Cleft formation may be seen. Areas of necrosis and hemorrhages are also present but more common in malignant lesions. Microscopic features, it is composed of both mesenchymal and epithelial elements. May well be circumscribed or microscopically invasive. The adipose tissue within the stroma is seen in about 1/3 of phyllodes tumor in biopsies. Epithelial component, there is elongated leaf-like epithelial proliferation which is similar to that seen in fibroadenoma. Squamous metaplasia of ductal epithelium can be seen. Mesenchymal component, there is an increased stromal cellularity in the periductal regions greater than seen in fibroadenoma. The cellular atypia or increased mitotic activity may be seen. The metaplastic changes are common in both epithelial and stromal elements. The metaplastic bone, cartilage, fat, or muscle can be seen in the mesenchymal component but more frequently seen in malignant tumors. Phyllodes tumor can be divided into benign, borderline, and malignant. The first two are only distinguished by the degree of cellular atypia and mitotic activity. Benign phylloid tumor. Generally, stromal cells are not markedly pleomorphic. Mitotic figures are few, that is less than 4 per 10 high power field and with well circumscribed edges. There is variable cellularity. There is minimal pleomorphism. There is low mitotic activity. The necrosis is absent. There are well-defined tumor margins. Low-grade malignant or borderline phylloid tumor. The tumor shows 2 to 5 mitoses per 10 high power field and moderate stromal cellularity. Malignant phylloid tumor. The tumors show stromal overgrowth and pleomorphism with little or no epithelium, increased mitotic activity and infiltrative margins. It has a sarcomatous appearance with increased cellularity and atypia. Heterogeneous mesenchymal differentiation may be seen. There is high mitotic rate, more than 5 mitotic figures per 10 high power fields. There is stromal overgrowth with loss of epithelial component. There are areas of necrosis. The tumor has infiltrative margin. Immunohistochemistry, cytokeratin, epithelial component is positive. Vimentin, stromal cells positive. Actin, desmin, variably positive. CD34 and beta-catenin frequently positive in stromal cells. Treatment in young girls, the surgical approach may be different for fibroadenoma with benign phylloid tumor. Excision with narrow margins is reasonable with fibroadenoma, but there is a possibility of recurrence. So phylloid tumor should be excised with wider margins. Lymph node dissection is not indicated because malignant tumors spread hematogenously to lungs, pleura, and bones. It may reoccur locally and malignant variant may metastasize. The metastases usually contain only sarcomatous component. ER and PR are not useful to determine the prognosis. This is the photograph showing gross appearances of phylloid tumor which is benign and show as a discrete mass appearing lobulated on cut surface without hemorrhages. Another photograph showing gross appearances which is a malignant phylloid tumor with areas of hemorrhages and necrosis. This is the microscopic appearance of benign phylloid tumor which show characteristic leaf-like pattern. Another photograph showing borderline phylloid tumor showing a spindle cell stroma, minimal atypia and increased mitotic activity. This microscopic photograph shows malignant phylloid tumor with markedly increased cellularity and there is periepithelial condensation. Another microscopic photograph of malignant phylloid tumor shows marked pleomorphism and mitotic activity of the stromal component.